Okay, so good evening, everybody, and welcome to Fertility Week webinar. This webinar is the third out of a series of 5, and it's going to be on Polycystic Ovary Syndrome. So Fertility New Zealand is a registered charity, and it's been operating for about 20 years. We're here to help people on their fertility journeys. And we do this by providing information. This is done through a series of leaflets. We've got videos on our website. We've got an 0800 support number and an email address. We also provide support through a variety of support groups throughout New Zealand. And we also provide advocacy. Tonight, our webinar is going to be presented by Dr. Stella Milsom, who works at Fertility Associates in Auckland, and she's an expert in PCOS. The format is going to be the presentation, and then we're going to do questions and answers at the end. So thank you very much, and I hope you enjoy the presentation. I'll let Stella take it from here. Thank you.
Thank you very much. Good evening, everyone. I hope you've all had a good day. I'm Stella Milsom. Some of you will know me. I'm an endocrinologist, particularly I'm a reproductive endocrinologist based in Auckland. I'm based at Fertility Associates Auckland with the University of Auckland in the Department of O&G and also at National Women's Health. So tonight the topic is the very common condition Polycystic Ovary Syndrome. Now, first of all, just to clear up a little bit of confusion, because you hear the term polycystic ovaries and you hear the term polycystic ovary syndrome, or sometimes it's abbreviated to PCOS. What's the difference? So first of all, polycystic ovaries. First of all, it's a very bad terminology. What we're really talking about is ovaries, and I'm going to show you in the next cartoon, ovaries that contain little follicles that haven't gone through to development. So this is not the same as an ovarian cyst that is larger, might rupture or cause pain. These are just little follicles which do no harm, cause no pain, but signal to the endocrinologist or the gynecologist that there might be some derangement, some changes in the ratio of female and male hormones. Now, polycystic ovaries have lots of little follicles, and the definition is maybe 12 or more in one or both ovaries, whereas an ovary that's not polycystic might just have 1 or 2 of those follicles. So it's not the follicle per se, but the number of follicles that makes the difference. And as I said, cysts is a really bad term, and I think it immediately makes people feel worried and bad about the condition, when in fact they're just tiny little underdeveloped follicles. And just coming through to show you this, that if you can see, and I'll see if I can move, yes, this is working. So let's just look on the left. This is a so-called normal ovary, and you can see that there's just 1 or 2 follicles at various stages in development. This is the fallopian tube, just ready to catch any egg that gets released from this ovary. Now, if we go over to the right, we've got the same ovary. Usually with polycystic ovaries, that ovary is a little bit bigger. So when we look at an ultrasound, we report on the size of the ovary. But you can see here, instead of 1 or 2 little follicles, there's quite a lot more. They're often peripherally distributed and they go right round the ovary. So the same follicles, but lots more of them. And by tradition, we would say that we'd want at least 12 in one ovary to make that comment that that ovary is polycystic. Now, the important thing to realize about that is that that's a non-specific sign. It doesn't actually mean that someone's got the syndrome. It could be because someone is very young. It could be because there are other issues such as being underweight, having a condition that's known, it's a complicated terminology, but hypogonadotrophic hypogonadism. There are other reasons. So that alone is not enough to make the diagnosis of the condition. We need more things that are going on. So what sort of questions would your doctor ask you, or would you think about yourself if you were wondering about if this condition was present? Well, hair. Now, we've all got hair. We've all got body hair. That's, unless you're albino, everyone's got a little bit of hair in various places. But when the hair is greater than average, particularly in the male type of areas, so upper lip, chin, chest, tummy, that male escutcheon going down to the pubic hair, on the upper or lower back, particularly on the thighs or the back of the thighs, or maybe on the arms, that particularly if it's dark hair and thicker, coarser hair, is more male type hair, and sometimes we refer to that as androgenic hair. So that could be a sign of polycystic ovary syndrome. Sometimes scalp hair loss. Remember, there are lots of other causes, but particularly if it's central scalp hair loss or there's some thinning up at the temples. Acne. Now, again, acne is a really common symptom, and lots of adolescents, boys and girls, get acne. But if the acne is particularly severe, if it continues, if it goes on into adulthood, if, for instance, you've had a course of isotretinoin or roaccutane and it relapses, there are perhaps times to think and ask your doctor, could this be because I've got a hormonal condition like polycystic ovaries? Infertility always worries people about this condition. In fact, most people don't have problems with infertility, but if the periods, instead of coming every 3 to 5 weeks, are quite infrequent, it means that someone's not ovulating as much, and again could be associated with a delay in fertility. When it comes to hormones, depends a little bit what's available to you and your doctor and what the local laboratory will do, and a lot depends on the quality of those assays. So again, always think about the person and their symptoms. Don't just read a blood test and take everything from there. So it's need to put the whole picture together. But in general, many women who have this condition are going to have an upper limit of normal or a slightly raised testosterone level. And sometimes the luteinizing hormone, abbreviated to LH, sometimes that's a little bit on the high side as well. Now, you could say, why do we even want to know about this condition? Is it simply a cosmetic thing? Is it all about acne and hair growth? Or is it about women and having babies? Well, there's more to it than this. And I think that if you see someone who's competent in this area, they will think beyond the immediate symptoms that you might be discussing with them on the first appointment to your future health, particularly what are your individual risks of metabolic syndrome, which really means insulin levels getting higher, insulin not working as well, leading to a risk of type 2 diabetes, cholesterol and blood pressure abnormalities, which of course in turn might cause heart disease. CVD is coronary vascular disease, and then a risk of endometrial cancer. Now, the risk of cancer is low, but it's important to realize that when it might be raised is if you've got this condition, if you're carrying too much tummy weight, and if the periods are not coming at all, or they're coming relatively infrequently. It's important to deal with that condition. None of us love having periods, and so a really common presentation to me is to say, well, look, I haven't had a period for a year or 2 or 3, and really I'm quite pleased about that. But from the doctor's point of view, that's a worry in terms of risk of thickening of the lining of the womb or even cancer risk. Now, if someone's presenting to their general practitioner, we've got to remember that it's not one size fits all. Women can be quite lean with this condition. So when you're looking at blogs or looking on the internet, and remember, just be a bit cautious. Go to professional websites. What's on the internet can be only as good as maybe what comes through your letterbox. So make sure you apply some discretion to what you're reading and how much credence you apply to it. So while weight is often mentioned with this condition, and certainly there is phenotype, that number 2, where women might have had this condition since before, really didn't know they had it in terms of symptoms, in terms of their skin, in terms of hair growth, and particularly in terms of periods becoming irregular, until they got heavier and more sedentary. And what happens in that situation is it's not the polycystic ovaries have changed. What's happened is the extra weight and the sedentary behaviour, as happens to us when we leave home, leave school, go to university, get an office job, are more sedentary in general. That the weight and the sedentary lifestyle increase insulin levels, and the insulin levels act on the ovaries to produce more of that male-type hormone testosterone, and in turn that causes the symptoms that we've been discussing. So that's a very common story. The other phenotype that we often see is women who are in fact very lean, so lean that we might wonder if they are underweight, if they've even got an element of an eating disorder, and that's where the period disturbance is coming. Sometimes that can be quite difficult for the doctor to distinguish between the two. And just occasionally, women have both of these conditions, but it might be that one is predominating. So it's not all about being heavy and having polycystic ovaries. Many women are quite lean. Does polycystic ovary syndrome in general cause trouble with weight, losing weight? Very difficult to find that data, and I think that we should assume that they're separate, but the two together, gaining weight, becoming sedentary, and having this underlying problem with your ovaries, it's not a good combination. Now, the next thing is, when do you know that there might be a problem and you should think about asking for help from someone? And probably the first situation might be to go and see your general practitioner. So if the menstrual cycle is not coming regularly, particularly if it's a longer cycle, it's more than 5 or 6 weeks, we start to worry about the lining of the womb, the endometrium getting thicker. That should be reported. Some women with this condition will have what we call dysfunctional uterine bleeding. They just bleed almost non-stop, and that can be really trying and troublesome. And of course, one would want to report that and sort out what's going on. And if there are no periods at all, remember, it might be appealing, but it's not safe on medical grounds. People will often come if they've got unwanted hair growth, and that might depend on your ethnicity and what you feel comfortable with. So that varies from person to person, and often people present with acne. So particularly acne that's persistent, or acne that's associated with body hair, and acne that's associated with periods that are infrequent. That constellation should maybe raise the possibility. And indeed, I saw patients today who had very astutely, without any health professional or medical background, they had figured out the combination of acne and hair and bleeding all the time. The possibility was polycystic ovary syndrome. So I was pretty impressed at that. Now, diagnosis. What do we do to diagnose this condition? Now, it depends, first of all, where you are in the world. And there's no generalized consensus, and that's really important for those of you, which is most of us, who are going to travel and live in different countries. So it depends where you live, what emphasis is placed on various aspects. This is not a disease or a disorder where one test diagnoses the problem. For instance, we can use a blood test and say if you've got diabetes, or you've got an underactive or an overactive thyroid. This is not the same. It's a syndrome, and we use a number of criteria, and if you've got enough of those criteria, we would make the diagnosis. So really clear cut, if we've got access to a pelvic ultrasound and you've got the PCO morphology, those little follicles, the multiple follicles, giving you the polycystic ovary appearance on scan. If your periods are infrequent or not present at all, and if you've got acne or hair, extra body hair, or losing scalp hair, or the hormone levels in the blood are raised, so that would be 3 out of 3 area, you would have the condition, with one proviso, that your doctor had just checked that it wasn't a secondary polycystic ovary syndrome picture. Now that's getting a little bit confusing, but basically, very occasionally, a tumour on the ovary or the adrenal gland, or an enzyme problem in the adrenal gland, or even a pituitary problem can present as if it's the common garden type of PCOS or PCOS, but in fact have another underlying cause. So excluding those, if those three conditions are present, it's likely you've got it. If you've got 2 out of the 3, the Rotterdam consensus is the common criteria we use in Australasia. So that means you could actually have periods provided the scan showed the polycystic ovary morphology and you also had these androgen or male hormone related symptoms, acne, hair growth. In other words, they have trouble not also having irregular periods. That's whether the diagnosis is going to be made in all parts of the world or just in Australasia. Now, what sort of treatment options are you and your doctor going to discuss? And it's important to remember in the consultation that you might go along with a specific problem that's really troubling you, which could be acne, it could be the body hair, which you're finding embarrassing and teasing, it could be the trouble with your periods, or it could be wanting to be pregnant. Sometimes the first time this comes up is when someone presents with lack of ovulation and a delay in fertility. Your doctor, on the other hand, might think about all those longer-term health issues I mentioned, your cholesterol, your blood pressure, whether or not you have diabetes, whether or not you're at increased risk of endometrial hyperplasia or cancer. So what's important is that everybody agrees what's going to be addressed and how it's going to be addressed and the progress that you're going to make. So just remember that could be that slight difference in view of what causes you to present and what your doctor might also want to make sure is managed for the sake of not just your immediate health, but your health for the future. Because that's the really important thing. It's not just about here and now, but it's managing this through the decades. What I often tell my patients is that the way they might present in their teens or 20s might be different to the way that the problems they might have in their 30s and 40s. The good news is this condition often gets better. It doesn't go away completely, but it often is a lot less troublesome as you get older. So there is quite a good window of hope at the end of that journey. So in the teens and in the 20s, it might be managing the irregular periods. It might be providing contraception and just checking at baseline that all those other health risk factors are being managed. It might be telling a girl who's been very fit and lean and who's studying hard and away at university, away from her mum's sensible cooking, and is packing on the weight and not taking regular exercise, that it's important to get back into a better lifestyle. You might be suggesting to someone that they never take up smoking, which is just another cardiovascular risk factor. Then the next thing about managing hair or skin, the next thing, as someone gets older, it might be coming back. Someone might have been on a birth control pill, for instance, plus or minus some medication to also help with skin, and might want to change tack and want to get pregnant. So it's a different tack again. And then later on, it just might be managing symptoms to make sure that someone's not getting heavy bleeding or even getting back to a sort of premenstrual condition. So what sort of things do we do? Well, first of all, in everybody, unless you're a really, really lean phenotype, it's important to be as fit as is practicable and as slim as is practicable. Now, I'm really tough. My patients are often quite taken aback. I suggest they should be at half marathon fitness. And some of you out there might say, oh my goodness. But what I'm saying is not just a gentle amount of exercise as it suits and when, but regular 6 days a week, a mixture of aerobic exercise, so that you're really improving the insulin levels and that metabolic risk and that tendency to diabetes as much as you possibly can. And that's in your power. That can be managed if you assign a priority to that. Now, being slim when your family genetics are against you and you've got a very sedentary job, I think most of us would that. All the endocrinologists would be slim if it was that easy. But nonetheless, this is a condition that it's really important to not, first of all, not to gain weight. So the earlier the diagnosis, the sooner you can recommend to someone that it's a lot easier if they don't gain weight in the first place than to try and get 20 kilograms of weight off when they're trying to be pregnant. So not gaining weight, keeping the lifestyle appropriate for you to manage it, and keeping exercise at a very good level, more than your average non-PCOS young woman, are really important factors. Similarly, as I mentioned, not taking up lifestyle factors that might increase your cardiac risk. So having your cholesterol checked, having a regular check for diabetes, and making sure you're a non-smoker. Now, you might say, well, how often do I have to do that? Do I have to come and see you or my GP every 3 months? Well, of course not. But as a slim, fit adolescent or in your 20s, when the family history is really good, no one's got early heart disease, early stroke, early diabetes, you might just need to keep an eye on those things every couple of years. But if you're overweight, if your mum's got diabetes in her 40s, if diabetes and heart disease and stroke run in your family, particularly at an earlyish age, under 60, you need more frequent monitoring. And you might need slightly more intensive monitoring. You might need to have a glucose tolerance test, which is the slightly more difficult test for diabetes, not just the single blood test of a hemoglobin A1C. Now, what else do people do? And I just want to emphasize that the good thing about this condition is that lifestyle, keeping it right, does a lot of what is needed. Many other conditions, it doesn't matter how virtuous you are in your lifestyle, it doesn't make any difference to the frequency of your epilepsy or even your asthma, whereas this is a condition that you have lots of input and can really change the outcome. Now, medication, it's not always required. The key time it would be required would be when someone's periods are not coming frequently because of the cancer risk. In terms of the skin and the hair, I let patients decide what they want, how much it bothers them, how much the nuisance of being on medication and coming for medical review, and we trade off those inconveniences versus benefits. But if they're troubled, acne that's persistent, if the hair growth is a problem, if they've got both, often people will want me to prescribe. And we've got a whole range of medications which start from quite simple medications. It could be just a progesterone tablet. It could be a low-dose birth control pill. Not used necessarily primarily for that's useful for men, but because a birth control pill has many actions which are positive for PCOS. We might prescribe what's called an anti-androgen, a male hormone blocker, as well. If we do, have to be very sure we've got good contraception, and it's usually helpful if we manage the periods in a different way as well. What about fertility? Now, again, obviously, if you're wanting to be pregnant, you can't be on a birth control pill and you can't be on an anti-androgen. So that might need a different approach. And again, if someone's presenting for the first time and they've got a little bit sedentary and they've got a bit chubby, often that's all that's required. A change in exercise pattern, weight loss. For many, just 10% off baseline will turn someone who's not having regular periods and not ovulating into someone who has regular ovulation. So that happens many, many times, and it's a really important starting point. Again, depending on who you consult and viewpoint, and of course other factors that might affect fertility, such as what age you are and whether there are male factors. But in general terms, someone with PCOS would be much better advised to work hard on their weight and lifestyle in the first instance. Of course, if you're a very lean phenotype, you've got no room for maneuver on terms of weight, particularly that abdominal weight. Those women may need medication to start them ovulating, medications like clomiphene or metformin, or a new medication called letrozole. Might even need a combination of metformin plus one of the others, and that again would be generally discussed with a reproductive endocrinologist or a reproductive gynecologist. This is not the sort of thing that would generally be done in the community. If you were wanting something in the community to help, the general practitioner could talk about metformin in that setting. The advantage of metformin, perhaps over the others, is it doesn't need the fertility program, it doesn't need a fertility doctor, such as myself or my colleagues, and it doesn't lead to multiple pregnancies and various others. Now, women are often worried that they've got this condition, they're going to need in vitro fertilization, and in general terms, that's not going to be the case. The odd person might be having a difficult course, but in general, many women with lifestyle modification, possibly with the addition of some medications, sometimes some other changes, for instance, even drilling, and this might sound awful, but if we're finding this a little bit difficult to get someone to ovulate, and we've moved through the lifestyle modification, we've moved through some tablets like clomiphene, we might even drill some holes in one or both ovaries, and sometimes that can just give things a kickstart. There are some injections that can be very helpful. And again, IVF is often something that's not needed, apart from perhaps the exception. It's certainly not the rule. But remember, IVF is very useful if there are additional fertility factors. So if there's also a partner who's got poor sperm or no sperm, or if the tubes are blocked, or if there's endometriosis, obviously those considerations come into where you come into this program in terms of fertility. I want to emphasize too that if we look at older women with polycystic ovaries and we look at the frequency with which they have babies, in fact, just as many PCOS women have babies as women without the condition. So just to be very encouraging and to point out, don't assume you don't need contraception. Lots of my patients have had little surprises. So just making sure that there's we're just keeping that in perspective. A point about IVF that worries me as a reproductive endocrinologist is polycystic ovaries, there's the risk of hyperstimulation. So that's just, again, very important that that's discussed, doctor and patient discuss that risk. If someone's going to have medications, even clomiphene, but particularly more the stronger medications, the gonadotrophins, or the really larger doses that we use for IVF, and there's a plan to just try and minimize that risk as much as possible. Now, we've already talked about self-help, and as I say, I think this is one of the really positive things about this condition. There's lots you can do. If you look on the internet, you'll find lots of people wanting to take your hard-earned money and get you to buy programs or books or join courses that tout to be specific for weight loss and managing PCOS. Really, none of that's true. If you get fit or fitter, if you can lose some weight, and if you can achieve it in any reasonable program or plan that works for you, works for your lifestyle, works for your budget, and that you can stick to, that you're not bored silly, that is all absolutely fine. And that's what the data shows us. There is no particular PCOS diet, even though, as I say, if you go looking at blogs or internet, you'll find a lot of people touting for your business. So it's finding something that's not absolutely crazy and you're deprived of essential nutrients, but aside from that, something that works, a program that works for you. And all of my patients with PCOS who are determined to lose weight do lose weight. They lose weight just as well, just as straightforwardly as my patients without this condition. But the key thing is really having that desire to want to achieve success. And No amount of lecturing from your doctor or from any other health professional is going to do the trick till the patient, the person concerned with the condition, is ready to do so. When they are, it works well. And there's lots that your general practitioner or the nurse at work or, perhaps one of the trainers at gym can do to help, but it doesn't require expensive, complicated programs or personal trainers. It requires a sensible plan combining attempting to lose weight and more exercise, something that suits you as an individual and you can stick with. So what's an ideal BMI with this condition? And again, there might be a little bit of shock horror here. I ask my patients, I first of all say, do what's practical and you can manage, not to make your life a misery, but with these tenets in mind. And if you could have a BMI that was around about 21 or less, that's probably perfect for this condition. Now, a lot easier said than done. So, of course, lots of people are not going to manage that, but just bearing in mind the importance of being at that leaner end of the normal range. Normal range is between 20 and 25. So that's a really important concept to grasp. It's important to remember ethnicity. So if, for instance, you're Polynesian, a normal BMI might be a bit more than that. And so it might not be a BMI of 21, it might be a lean BMI for being Polynesian might be more like a BMI of 23 or 24. Conversely, if you're Asian, from the Southeast Asian continent, you might be developing heart risk factors when your BMI is only 21 or 22, and more normal might be perhaps 18 or 19. So ethnicity is really important as well as the advice that I'm giving. So just general concepts and bearing in mind what's appropriate. So sensible food plans, lots of exercise, and considering for you what food plan makes you achieve weight loss. So I hear, and I'm going to be probably a bit provocative and controversial here, but I will hear every day someone will say, oh, doctor, I'm eating really healthily. But I say, look, I'm about objective measures. Is your waist measurement decreasing? Is your weight decreasing? So if those measures aren't changing, then the eating plan might all be consisting of good choices, healthy food, but it's still too much of it. So it's important to just remember that.